Okay. Welcome everyone in the room and online to January, freezing cold, our first IQ Forum of 2026. So glad to have you all. Super jazzed about the year. My name is Stacy Farr. I think everyone in the room here knows me, but there's plenty of you online as well. So nice to meet you. I'm the co-director I work with alongside Pat and John Spertus here on running our Healthcare Institute for Innovations in Quality. So lovely to have you. I'm going to give just a little bit of an overview before we jump into our really great lineup of speakers today. So this is our new lineup for the year. So these are the topics we'll be covering for this year. We are here on our first one, obviously, as we can see, on January 29th, where we're talking about patient and workforce engagement strategies to improve satisfaction and care. And then we'll be meeting again in every other month. Then you can see our topics lined out here. We really hope you'll join us. And we do want to make sure that we thank all of our sponsors here. So we have a number of valued people who sponsor and support our work, and we're really grateful for all of them. BioNexus KC, Frontiers Clinical and Translational Science Institute, Health Forward Foundation, and UMKC for supporting our IQ forums. So today brings us to today. I know we're not here to listen to me, so I'm going to try and power through the overview. But in an industry defined by high stakes decisions and high stress likelihood is also high that excessive turnover of staff in all positions will diminish the quality and quantity of services provided to patients. Engaged staff are more committed, attentive, and resilient in their work, and this requires thoughtful and sustained strategies that foster a virtuous cycle of engagement to directly impact staff retention, patient care, financial performance, and ultimately organizational success. And this IQ Forum is an opportunity to glean insights from the state of U.S. healthcare workforce from several different perspectives and hear strategies being implemented to improve satisfaction and care of both the workforce and of patients. So that being said, I didn't have it up there. Just a few other quick thoughts with the bullets that flew like wildfire. Well, this is a gigantic workforce. I just wanted to share there are 17 million people who work in healthcare, just kind of giving you an understanding of some of the scope of what the workforce is here. And in 2020, IHI and AHRQ, the Institute for Health Improvement, and the Agency for Healthcare Research and Quality unveiled the National Action Plan to advance patient safety. And while patient safety is, I know, a little bit indirectly tied to the improving satisfaction and care, there were 4 pillars that also overlap a lot with today. So I just wanted to highlight those, which were culture, leadership, and governance, patient and family engagement, learning systems, and also workplace safety. And then in addition, we all know the quintuple aim as well, which, really has kind of pushed the 5 different pillars of advancing health equity, improving population health, reducing healthcare costs, improving provider well-being, which is exactly also part of what we're talking about today, and enhancing the patient experience, also important for today. So quintuple aim is really important and salient here in this topic today as well. And while, context will differ across all these different settings, clearly engagement strategies really do improve care. And so learning here together will help us be able to apply learnings and take them back to our own organizations and practices and make care and satisfaction higher. Couple of citations there. So with that, we have a really fabulous lineup today of speakers and making sure my lineup matches here. So first, we're going to hear from Will Franklin, who is the Chief Executive Officer of KC Care Health Center, who's going to be giving us a federally qualified health center perspective on culture as care, organizational culture as a driver for quality and outcomes. And then we'll go through, I'll introduce the rest of the speakers as we go. I just wanted to highlight as well before I turn the floor to Will that next month we also have, just so everyone knows, you can go ahead and register. We have the Changing Federal Landscape and What is the Future of Regional Healthcare. So we do hope you can register and attend that one as well. And then one tiny plug is our Tiara program, which is another program of our Healthcare Institute for Innovations in Quality. It's a training opportunity. It offers CEs and a certificate both from our institute and from Frontiers Clinical and Translational Science Institute is launching. Our next cohort kicks off. We're enrolling people now, and we're kicking off fully on February 9th. So if you know anyone who would be interested in this training, it's really at the intersection of implementation, science, and quality improvement. So I just wanted to share that. And
And before we go too far, we got a message that those online are seeing presenter view. So while you keep going there, I'm going to go get tech.
okay.
Okay.
All right. Well, I hope you've enjoyed presenter view online. I'm really sorry about that. I wish is there a way to duplicate so you only
John,
see
on it. No, this
perfect.
is not the lead screen.
Okay, so with that, I escape
So let me go do it.
here. And do you have slides, Will?
I do.
Okay. And then I'm guessing you're in here. I'm not sure. I probably needed text. I don't know where she put the slides for everyone, but we're gonna call these maybe on the desktop.
Nice slide deck.
There. Yeah, perfect. So and I know that we don't have it. They're seeing this right here, and just so you know, but until we can do this. So they're seeing this.
So if you go to swap.
Well, I don't want to swap because then it just moves it to the room. That's where they duplicate. That's what we oh, but then nope, that's not what we want. I mean, because then the problem is, did you have notes you wanted to see? Probably.
I can go with that. That's fine.
Oh, because that's the only other way I can think of it is to duplicate, right? Cool. I mean, because that'll at least get it so everyone sees, but for anyone who has notes, that won't necessarily.
Sorry, everyone. That is good.
Yeah, we should write these down. So we'll have to write down next time. So we just did it so it duplicated the view, but now the presenter can't see
their notes.
Yeah.
But is that okay? Is everyone okay?
I mean, it's really up to the speaker.
Becky, will you be okay if you are not seeing
it was online? People were seeing.
You'll see that.
Yeah.
Okay. We're good. We can carry on. Okay.
So they were seeing the notes and stuff.
Okay, let's carry on.
Don't share that.
Okay, perfect.
We can be flexible.
Thanks, everyone.
Good afternoon, everybody. Can everybody hear me okay?
Yes.
Online and in the room. For context, my name is Will Franklin. I serve as the CEO of Casey Care Health Center. My background is actually I'm a behavioral health clinician by training. I stumbled into an administrative role one time and it seems to have stuck. I don't know if I lost a bet with somebody. I don't know. But here I've been at Casey Care now for about 6 years. We are a federally qualified health center. We serve about 22,000 patients across the metro area, across 3 locations. We've grown significantly probably over the last 5 years. We offer primary care, behavioral health, dental, we have a pharmacy, and we also are the largest HIV provider in the region as well. So because of that expertise, we end up treating a lot of folks with other infectious diseases as well. So that gives you a little bit of overview and kind of as a pretext to this. We've been a national Great Place to Work certified organization for 2 years in a row now. And that was the result of a lot of hard work and intentional work the previous couple of years. I will say, I have to remind people all the time that the certification actually isn't the goal. It's a nice thing, but we actually started going through the process as a means to measure and improve. So, and I'll talk about kind of the nature of kind of quality improvement and our workforce. And so when I think about my historical kind of career and quality improvement, I was a COO of a large FQHC in St. Louis for a long time. One of the biggest challenges that we were running into sometimes is turnover in the workplace, right? And it wasn't necessarily always providers, but it was medical assistants, nursing, even front desk staff. Those types of things can be really disruptive to the workflows, to processes. It also increases reliance on workarounds. Now, I've stopped trying to fight workarounds with providers because I think they're smart and they find cool ways to do things. And actually, a lot of our quality metrics are not a result of people not doing the work. It's not documenting in the right place at the right time, right? 90% of it is that. And so I remember when I first started at Casey Care, I would hear people like, well, I do it this way, right? And they would take me through this workaround, right? But I have learned that actually it's important to embrace that, but I thought it was more important that we focus on reducing turnover. So 6 years ago, in our kind of frontline and clinical staff, we had about 60%, about a 60% volunteer retention rate. And some of that was just the nature of the workforce. There's external factors involved, but I felt like that was something that we could try and manage. And so we did a lot of work. The certification process didn't start with just improved benefits packages and things like that. It actually started with some really intentional efforts around strategic planning too. So really, we thought about it as kind of culture is an operational strategy for us. And so when we think about what does that mean, it's leadership behaviors and trust, psychological safety, staff and patient voice in the process. And then we wanted to link culture explicitly to performance. And so we really kind of took our values as an organization and put them into a culture code. And so the strategic priorities that we operate under right now are basically, we want to be a great place to work. We think that that's important. We think a happy provider team and a happy workforce translates to a better patient experience, which in turn will result in higher quality metrics. We want to be our patient's first choice for acute, preventative, and support care. And then lastly, we want to be able to sustain. We want to be able to do what we do really well so that we can take it to scale. And so when we grow, we're growing in a smart way and not just growing for the sake of growth or to achieve volume. And so when we come back to kind of what this translates as our values in the organization, this culture code, I have my other badge on, but my normal work badge, this is on the back of everyone's badge. So the strategic priorities and our culture code on the back of everyone's badge. And so we kind of, new employee orientation, we often take our badges off and lay them on the table and say, well, when things get tough or you're trying to make a complex decision or something that feels like a lot of conflict around it, like, just look at this. I mean, put patients first. Nobody's ever going to get in trouble for erring on the side of trying to put patients first. And so we've really leaned into this over the last several years. And so with our strategic planning process, we actually walked through we had multiple groups run at one time and basically ended up pitching strategic ideas. We had even a patient focus group to our board, kind of Shark Tank style, where they poked holes in stuff and came together. In the process, we also created a lot of feedback loops. So we had a lot of opportunities for staff to give feedback. I gave some examples here, and I think this is kind of key to culture is listening. So we put listening into action. So when people gave us feedback around things, we tried to listen and really follow suit with that. About 5 years ago, we started, it took us about 2 years, but we did pay equity and market analysis to look at where everybody who worked in the health center was, not just among FQHCs, but in the healthcare marketplace. Because we felt like if we were going to be a provider of choice, this wasn't about just being a safety net provider. This was being competitive in the larger healthcare arena. And so it took us about 2 years, but everybody who works in the health center, it doesn't matter your role, is at or above market right now. We started tuition reimbursement processes. We have monthly kind of informal processes to get feedback. So we do like a lunch with leaders thing, and it's a randomized group of staff who come and give feedback. What's working? It's kind of like mini start, stop, continue conversations, right? What are we doing that's really working really well? What do we need to stop doing because that sucks and everybody hates it? And what are some other things we need to think about? So the other piece was when I started Casey Care, I started about a couple months before the pandemic hit, right? So that was really awesome to start a new job, new city, right in front of a pandemic and in a healthcare organization, right? But one of the things that I loved about the pandemic was that all the rules went out the window. That was my favorite part. That's the part I keep trying to recreate all the time because I don't like all the rules. We have so many processes and procedures and regulatory things that become routinized over time that sometimes actually don't have anything to do with patient care. And our providers get frustrated with that. And so a lot of what we have tried to do is to try and take the same ingenuity that applied during the pandemic and try to apply that to everyday scenarios and keep that kind of fresh idea space alive. And so by doing that over time, we've been able to not only improve quality metrics, and I'll give some examples of those here, but we've been certified as a national great place to work 2 years in a row. And so, I think there's a threshold of like compared to other organizations, like 91% is our kind of final grade, if you will. I think you have to get 60% on a survey tool. And once again, the survey tool that they use, the goal necessarily wasn't to get certified. It was to give people used to giving feedback and feedback that mattered, right? And feedback that wasn't performative, but yet also recognizing that when you get feedback, you have to do something with it, right? And I think that was critical, is people had to see you're serious about listening to feedback. And if we couldn't do something, we gave them reasons why. Like, well, that's a great idea. We don't have the budget for that, but let's, put it on the whiteboard. Let's explore pieces or parts of that and move forward. But so we're sitting here now, and we have about a 97% voluntary retention rate. And that creates stable clinical teams, right? So now the work isn't necessarily about workflows or process improvement. It's actually increasing the reliability of all those things and scaling that. So when we do have quality improvements or PDSAs and things like that, it sticks because the workforce is congealed, the teams are intact. And so we operate kind of under this assumption, and I would hope this is nonprofit management 101 for everybody, but this is kind of our hypothesis, right? Is that we have our mission, and if we do a really good job with internal service quality, that will, and that's the relationship that our team has with the organization, that impacts production and retention. It creates external service quality, creates customer satisfaction. And then for us, we have a lot of value-based care contracts. We're in a Medicare ACO. So almost everything that we do and the reimbursement that we get is not tied to how much volume we do, but it's how well we're doing what we're doing. So therefore, loyalty is key because we can't do repeated measures of anything to improve quality unless people come back to see us, right? And so on average, our patients see us probably 4 or more times a year. And so that customer loyalty piece is the magic in terms of quality improvement, right? When people come back with repeated measures of their blood pressure control, their hemoglobin A1C, well, that's when we start to see the needle move, is when we do those repeated measures. But this team stability is really what drives that. So if you lay kind of the strategic priorities on top of this diagram, it's pretty simple, right? And I do this presentation for new employee orientation all the time. Hopefully everybody that works in our organization understands this diagram, right? And that if we're an employer of choice, it's a lot easier to be a provider of choice. It's a lot easier to have positive growth management. And then when we do that really well, we reinvest in the mission. So I'm going to give some examples of some clinical measures, but I think even from a financial perspective, I think it's important to note that in 2019, out of the pandemic, KC Care, 4 days cash on hand, and we had about a $17 million budget going into the pandemic. Right now, we're not spending a lot right now because we're also that next topic of the federal landscape is pretty murky right now, but we're sitting at 120 days cash on hand, and we have about close to a $40 million budget now. And so it has translated into financial success as well because of those quality metrics. So just to give you some examples of kind of point of care we thought about staff stability, turning that into reliability. So obviously when you have consistent staff, your workflow, rooming patients, how people get all of the point of care measures, those initial screening tools and things like that done. We have a ton of screening tools that we have to do as an FQHC connected to social determinants of health. Well, if you get a certain score on that, it triggers a referral to behavioral health. There's lots of rules, right? But the more congealed our staff is, the better we get at managing all of that, and the less workarounds that we have to. So here's just a couple of those measures. So this is just in the last 2 years. So body mass index screening and follow-up for folks 18 and up, right? Seems like a simple measure, but the reality is this is documentation, right? And consistency. Same thing with depression screening and follow-up. So the first one, we're way over our what we consider our goal measure is for that. And these are all UDS measures from the federal government and CMS that were measured on. And then depression screening follow-up was another one. And so we've had an 11% increase in the last 2 years. And these were measures that we were actively working on. We had a lot of measures we were doing well with and some we weren't doing well with. And these are some of the ones that we weren't doing well with. So those are the ones I chose to focus on for today. And if you think about hypertension control, so in the last 2 years, we've had a 6%, over 6% improvement. And once again, we didn't change the process. The process just got more reliable over time, right? And so I attribute this. I mean, I'm not plugging this all into a regression analysis or anything like that, but I attribute a lot of this to this team stability, right? And we have lots of measures like this. These are just some examples I wanted to kind of throw out for you, and to get you thinking about this. So what we've learned, though, is that our patients really appreciate lack of turnover. Our customer service, our NPS scores are really high. They're through the roof right now. We set a goal of trying to get having a 70% or above, and we're well into 80s, approaching 90% patient experience scores right now. And a lot of that is connected to intact team that doesn't change much. Relationships are important to our patients. Every one of our sites, we really try to move away from the idea of kind of legislating how people do things and focused on, okay, these are things that have to get done. This is the what has to get done. But let the clinical teams on the ground figure out how, right? This is just what we're measuring. This is what we have to do. And we found that like every site across the 3 sites, they all have different building configurations. They all have very different patient populations. So our Midtown campus, if you walk in there and you don't see someone with blue hair or a nose ring, they'll walk back out. At our research medical center, it's more young families, moms and kids. At our Northeast site, you can be there for probably 2 hours and not hear English spoken. All of our providers there are bilingual. So we really let the teams decide how things get done, the order of operations, because they knew the patients the best. And I think that having some locus of control, understanding what the goals were, being really clear and setting kind of our strategy as a part of our culture, helped align people around the goals to where our clinical quality outcomes are now matching everything else. And so we really think of this, our culture and our strategy kind of being linked together, and being a great place to work is really a core piece of population health management. Now our staff is trying out ideas. We have community health workers, similar to a lot of organizations. We've kind of decided, well, we have so many patients that the minute they walk to the front desk, they just kind of tell you everything that's going on. And a lot of times that person's at the front desk is like, well, I can't help you with all of that, but I'll let you talk to Pat or so-and-so. And we're trying to reduce the number of people. So we moved community health workers, called them patient health coordinators, and moved them right to the front desk, right? So that they're trying to get as many needs met at that point of care. Because I can tell you, even if I'm downstairs and I just open the door for somebody, I'm like, hey, where are you headed? Do you need some directions? And they tell me everything about what they're there for and stuff that I don't need to know, right? But knowing our patient population, what their expectations are, them having a voice in the process, and our staff having a lot of locus control, I think has really impacted all of our quality metrics. We're now our Medicare ACO program, we're past the point of achieving cost savings. We're now getting kind of those payments back because we've achieved all the metrics that we need to in those first couple of years of the ACO. And really in a world where Medicaid reimbursement is dwindling, that's really becoming our replacement source of revenue, right? So we're leaning into these things. It's not just financial strategy, it's not just the quality improvement strategy, but it's culture. And the thing that we find is, well, it's never the wrong answer to invest in our people, right? So I'll stop there, throwing a lot of information at you. And I know we're gonna do some Q&A later. I want to make sure that we give time for everybody else. So stop there, but happy to answer questions later.
Thank you.
Yeah, that was great. Thank you very much. I love that quality financial people culture strategy. I love this. I learned a lot. So that was great. And now we will turn it to our second speaker. So here we'll be hearing a payer perspective on psychological safety in the healthcare workplace. So we'll be hearing from Dr. Rebecca Kernan. Good to see you again. Who is
Good to see you.
Medical Director of Family Medicine, Commercial Clinical Appeals and Commercial Clinical Operations, Health Solutions, long funded, I'm still going, and at Anthem Blue Cross and Blue Shield. So the floor is yours.
Hi, everybody. As I was preparing for this and got Patricia's kind invitation, I told her, Ash, do I really want to tell these people that I work for a payer? Because my heart really is that of a primary care physician, practiced for 20 years or so. And an area of expertise for me is integrated behavioral health. So as I was driving here, I thought, I'm given the talk about psychological safety. So I should probably assume that the crowd is going to be a psychologically safe place to say, I work at a payer and it's all okay. Not really, but exactly. Good. Thank you. Thank you, Will. So I love the common themes.
They're not seeing the right thing.
Oh, okay.
Are you online? People online, you're not seeing the right thing, are you? Can someone answer online?
Sorry, no, we're not.
Let's do the same. Oh, that's odd.
Yeah, they're not seeing it. Oh, they're seeing the whole screen. And I see.
We stopped it once. Oh,
I think
but
I know why. We
we
need
have to
to,
close
instead
it.
of sharing a presentation, we need to leave it on share screen. Now, hopefully it's okay. Is that better?
It is. It's perfect.
Yes.
We see it now.
Thank you. Thank you. So I love the common themes that we're already finding that we're hitting on. So I titled my talk Psychological Safety in the Healthcare Workplace, and then, in pursuit of that quintuple aim. Many of us will remember just a few years ago that we hadn't even evolved to a concept of the quintuple aim. Many of us were on the edge of that, thinking these are the kinds of ideas we need to be adding to include that health equity piece, of course. And then years before that, the clinician well-being, care team well-being. And so Will touched on that, and I'm going to pick up that ball and roll with some of the things that Will started to bring up. So today I'm going to try to hit on really two of these in a more robust way, leaving you with some resources and ideas to try to build psychological safety on the teams in the organizations where you all work. So again, the quintuple aim. I liked one of the things that Will said. The goal is not no turnover or any of these things. The goal is the quintuple aim. And those foundations that we build on our teams and in our organizations are so critical to our ability to achieve the quintuple aim. So where does this idea come from? Who in the room has heard of the term psychological safety? Yeah, most of you, and I'm guessing the folks online may have had some experience with it. So I think the best way to talk about psychological safety and what it is sometimes to talk about what it's not. This idea has gotten more traction when Amy Edmondson, who is closely affiliated with the Harvard Business Review and Harvard teaching institutions, wrote this book called The Fearless Organization. And you can see the definition that she likes to use. There are some others online that you can find, but I think this will resonate with all of us, whether in the workplace, at home, in our friendships, even sometimes. Psychological safety is a belief that one will not be punished or humiliated for speaking up with ideas, questions, concerns, or mistakes, and that the team is safe for interpersonal risk-taking. Now, we all know what it feels like to be in a meeting and feeling like there's a thing that needs to be said at this table, and sometimes taking an inventory of ourselves. Am I the person to say it today, or is the guy next to me going to say it? Or I hope my leader says it. But sometimes we are faced with those big, bold moments that feel big and bold inside. And it's a risk. We recognize it as a risk, maybe a risk to our sense of confidence or in our organization. So many difficult things going on in healthcare. So think of it as the ability to take an interpersonal risk. Also noting that just like when we're caring for our patients, this is going to differ from day to day. There are days in my career where I have felt big and bold and raising my hand. And then there are other days, not so much. And so this is very fluid, right? This is a very fluid concept. The other thing I'm very aware of is that this really depends on your cultural background, the family you grew up in, the neighborhood you grew up in, your traditions, ethnicity, other demographic factors. It really depends. And that plays out every day. And so what's psychologically safe to me might be very different than what feels like psychological safety to Will or Patricia or Stacy, the faces that I know here in the room. So I like this slide. As I talked about, I think it's easiest to think about what it's not. Now, we've all been in rooms, in meetings, in family gatherings, where we can identify what's not psychologically safe. It's like Ronald Reagan in the 1980s. When you see pornography, you know it. You can't describe, when you see it, you know it. This is similar, probably not the best topic, right? For the say in front of a quality forum. However, it's the quote that comes to mind. When you see it, you know it. When you feel it, psychological safety, you know it. And when it's not there, you really feel it, I think. So I think it's important to talk about what psychological safety is not. It is not saying anything you want in your organization, on your teams. It is not letting your emotions go all over the place as you please. It is not our leaders taking sort of a less than assertive approach, or leaders correcting things that need to be corrected, or taking a hard line, or making the changes with the help of some change management expertise. It's not a space free of any inner discomfort. We'll talk about that in a little bit. It's not about taking risks and hoping for the best. It's a calculated risk when you raise your hand in one of those meetings, and you've probably weighed the risks and the benefits, and it's a calculated risk, but it's not all holds barred type of risk. And it's certainly not everything is tolerated. I'm losing my I'll stand right here for a minute here. So the other things you guys, I'm not going to read to you, but you can see on the right hand or the left hand side of the slide, it's not a shield from accountability. It's not just niceness. It's not coddling. It's not decision by consensus or committee. It's not unearned autonomy. I'm going to skip political correctness. Who knows what political correctness is in our climate right now? And it's not rhetorical assurance. It's not patting on the head. I think an interesting question to get at this on your teams with your colleagues in your organizations is how comfortable might it feel to cry in front of your boss? You know, it's an interesting question. I had a different take on my answer to that question than one of my colleagues, and we were from very different backgrounds. And the answer to that question really showed up. We were trying to hire a new leader. And one of the questions was, how comfortable might you feel crying in front of this person, this candidate? And my response was, gosh, I think that's really important. I think if you're having a bad day, you feel trust and close to your leader, that if you have emotion that spills over into tears, I think that's okay. And I think in a healthcare organization, your leader should be expected to handle that. My friend, my colleague, thought exactly the opposite. Absolutely not. It is never acceptable. It is never okay. So that's an interesting and lively discussion to have. Now, crying in the workplace is probably mostly going to be frowned upon. But think about those times when you really needed to confide in a boss, a colleague at work, and think about how safe that feels or doesn't feel. And so think about your leaders, and when we're hiring and when we're taking folks on, think about those kinds of questions and challenge our teams maybe with those sorts of things. Okay, so I like this slide because it demonstrates, you can see on the various axis lines, accountability becomes higher and psychological safety becomes higher. Guess where you land? You land in the learning zone, where collaboration and learning happen in the service of high performance outcomes. And so I like to spend a minute also looking at the apathy zone, for example. Low psychological safety and a real feeling of being not accountable for work outcomes, feeling disconnected from the work you do, not understanding how the work you do maybe contributes to the overall mission, vision, goals, and certainly in the quality arena also. So the goal is not comfort. The goal is not to make us all 100% comfortable in our workplaces, no matter what our role is. I think a healthy amount of discomfort is really important, especially in today's climate, in the healthcare environment that we're all stewing in all day long. I don't know about you guys, but thinking about being a physician practicing medicine looks nothing in 2026 like I thought it might when I started medical school in 1997. And so thinking about the discomforts that keep us up at night, the patient that we're worried about, all the things. We don't want to be comfortable in healthcare, but we want to have that sort of healthy anxiety, I guess. And so it's important, I think, if we're going to teach this concept to our teams, to really make the delineation between comfort and psychological safety. Okay, and why does this matter? Next, why does this matter to healthcare organizations? This is probably pretty obvious, but this is when a picture is worth 1,000 words, I think. Oops, before the pictures. We have a study done by sort of the techie world about the business impact of psychological safety, showing a direct link between business outcomes in an industry very different from ours. Well, I should stop. Maybe not so much, maybe bleeding into our industry these days, but take a look and digest the quantifiable business outcomes that are derived from a sense of psychological safety. That foundation allows for those risks, allows people to make the changes, the innovations, the raising of the hand in a meeting, even when it's hard. So a picture's worth 1,000 words. Again, why does this matter in healthcare? Think about, what if one of these folks accidentally leaves a sponge during the operation? How safe, how comfortable is it for one of those folks to say, hey, I think we need to go back, at some risk to everyone involved, including quality scores, including surgical outcomes, and say, hey, I saw an extra sponge in there. And to have to open up the OR again, I was a medical student. You guys may find this a scary thing for me to say, but I was a med student who a couple of times itched my nose in the middle of an operation, and they had to take down the entire operating suite because I was all gowned up and gloved, and I scratched my nose, and I was terrified. You know, I was a first or second year medical student. But the tension in these rooms when something like that happens, when a silly med student makes a mistake like that, or, you know, when something more substantial happens. Think about this environment. Many of us have sat at these kind of tables. When something needs to be said, there's maybe some discomfort with the decisions being made. It's really hard. There's really high stakes. There's really important discussions that need to happen, those crucial conversations that we talk about sometimes. Think about an incoming class of medical students and the world of medicine that they're entering into, very different, like I said, from when I started, or many of us started in healthcare. How critically important it is for incoming professional students, folks making their careers in healthcare law, or on the business or administrative side, that they're beginning their training to learn these kinds of things. And then this one, you know, is obvious, a medication, an opportunity to make our workflows and our processes in line with patient safety. But gosh, we're going to make mistakes sometimes, and we know from all the studies that it happens on a daily basis in our facilities, in our organizations and institutions. Okay, so how can we, as leaders in our organizations, start conversations designed to create psychological safety, designed to show accountability and show some vulnerability as leaders that creates those environments? I've listed a few different things here that hopefully, Patricia, I don't know if some of these links will be available to folks or not, but the Harvard Business Review content that I mentioned, with not only the book by Dr. Amy Edmondson, but also some really good articles in the Harvard Business Review about the importance of psychological safety in many, many industries. There's some really fabulous LinkedIn learning content on this that folks at their organizations who have HR departments that, like LinkedIn Learning, for example, usually the bigger organizations, folks will benefit from lots of courses. I plugged in a search and there were 10 or 12 different courses on LinkedIn Learning that people can get credit for. And then I really like the American Psychiatric Association Center for Workplace Mental Health. Lots of good resources aimed at clinician care team, well-being, resilience, and creating these safe, psychologically safe places. This is an example. You can't change it unless you measure it. All of us understand that very well from quality, and there's some really well done and thoughtful ways to survey your teams that you work with. To start with an understanding of how psychologically safe is our organization, is our team, is our micro team or our dyad even sometimes working. And this is a good resource that is also worth taking a look at. This actually comes from MGMA, Medical Group Management Association. Leader behaviors, attributes, skills, words to say, and ways to make it very well known on your team, if you're a leader, that you intend to create an environment where we're going to aim for that quintuple aim, but in so doing, we're going to create spaces where people feel comfortable taking those risks with bringing ideas and innovations forward. And then here's some quotes and ideas that I like a lot from various people, poets and thinkers and others. There's one I was going to call out. Yeah, it's not a poster on the wall, right? We've all been involved in initiatives or organizations where we see the poster in the bathroom and have checked the box, but this is a deeper rooted kind of thing. And there could be posters, I guess, but it's not a poster on the wall opportunity. It's a really grassroots effort at building trust and altering the landscape of the way we talk, think, speak up, and make our voices heard when we are those agents of change in our institutions. Thanks so much for the opportunity.
Online bills, sugar. Okay, thank you. And I did drop your links in the chat.
Great.
And anyone in the room who wants those links, just reach out to me and I'll make sure you get them.
Thank you very much for that talk. Dr. Vernon, that was great. And so now our next speaker, we're going to turn it to a shift in perspective and hear a pediatric workforce and policy perspective. We'll be hearing from Jane Kaplan, who's the Senior Director of Policy and Regulatory Affairs at the Children's Hospital Association, on securing kids' futures, bolstering the pediatric workforce. So Jan is online, I believe. I'm looking.
I am, but I have to figure out my technology. Hold on.
Yeah.
So let me share my screen if it works. And you can all tell me what you're seeing. I think I have to put this in.
It looks great.
Does it still look great?
Yes, it still looks
Oh,
great.
okay, good.
Thanks.
So thank you for inviting me to speak today. I'm going to talk to you about the pediatric workforce, and from a slightly different perspective than from what you've been listening to thus far, in that it's going to be a little bit, I don't want to say maybe more of a global view, because I'm coming to you from Washington, D.C. And so and from the federal, looking at things from the federal policy perspective. So hold on 1 second. I just need to fix my own screen here. 1 second. Okay. So today I was asked to give you an overview of pediatric workforce shortages, what's driving those shortages, and a sense of some of the policy solutions that we have at our fingertips to address some of those shortages. I'll also give you a quick snapshot of the Children's Hospital Association, and a fun fact for those of you who don't know this, we do have a large cadre of Children's Hospital Association folks there in Kansas City. We actually have 2 offices of the Children's Hospital Association. We have one in Washington, D.C., where I sit, and one in Kansas City, Kansas. So I have been out there many times and actually really like it out there. So what is the Children's Hospital Association? And I just realized, no, okay, I'm good. What is the Children's Hospital Association? We are the nation's leading advocate for children's health. We unite children's hospitals across the country to improve care, but also to amplify our impact. We represent more than 200 children's hospitals across the country, and we range in size from large freestanding children's hospitals like Children's Mercy here in Kansas City, to much smaller specialized hospitals like the Shriners and some of the other smaller rehab hospitals that really focus in on more discrete aspects of children's care. So just a few quick facts about the nation's children's hospitals. We are only about 3% of all hospitals nationwide, but we treat nearly 50% of all children admitted to a hospital. We provide specialized care to very sick kids, including almost all of cancer care and care for rare diseases. Children's hospitals are also centers for pediatric training, not only for more than 50% of pediatricians and pediatric subspecialists, but also for pediatric advanced practice nurses, pediatric respiratory therapists, pediatric physical and occupational therapists, pediatric pharmacists, and pediatric researchers, just among a few. And children's hospitals, though we're few and mighty, so to speak, we serve large geographies. So it's not uncommon for children to travel long distances to a children's hospital to get care. It's also very common for pediatric specialty providers of all types to be located near or in the surrounding community of a children's hospital to provide that care. And often our children's hospitals are located in more urban areas. So Children's Mercy gets kids from all over who will actually travel across state lines to get that care, may fly from distances if they need the specialized care that only Children's Mercy can provide. So I sit on the public affairs team here in Washington, D.C. at CHA, and our role is to really advance policies that bring children front and center. We spend our time reminding policymakers and external audiences like you all that children are not little adults and that children's hospitals play a unique role in their care. And we need policy solutions and approaches that reflect that uniqueness. So we've been talking about today, and we've all heard this, we know we're all facing a healthcare workforce shortage across the country. What makes pediatric workforce shortages different from those that they're facing in the adult space is that the adult workforce shortages are more prevalent, not solely, but more prevalent among primary care providers. In the pediatric space, it's more prevalent among the specialty providers. So the data that you see here comes from an assessment we did of our member hospitals, of our member hospitals back in the fall of 2023, where we did a survey of them to really get a better sense of the impact of shortages across pediatric health professions. And we looked at vacancy rates and we looked at wait times. So what you see here is what our children's hospitals reported. And you can see that they reported significant vacancies amongst pediatric physicians in a number of critical specialties. And 3 out of 4 of those shortages that were most severe were in the behavioral health, mental health, and neurological areas. And you can also see here where the major pediatric non-physician shortages are. So respiratory therapists, I know that had really came to light during the pandemic, and it continues as we face RSV and other respiratory illnesses moving forward. A lot of areas around related to mental health again, and then some of those med tech, imaging tech. And the difference in here is that these folks have to be trained specifically to treat little kids or kids of all ages. And the other issue that we looked at, as I said, was wait times. So we have these vacancies and we got a sense of what the impact was on wait times. And in these areas, particularly in say, for example, the genetics and developmental behavioral pediatrics areas, wait times are significant. So our hospitals are seeing wait times up to 21, 22 weeks in those areas, which is significant when you've got a little kid that really does need care. So let's look at the reasons for the types of shortages we're facing in pediatrics. Some of them are similar to adults and some not so much. And first, it's important to understand the critical role that Medicaid plays in children's health and how that impacts the pediatric workforce. So just first, a few key facts. Close to half of all enrollees in Medicaid and the Children's Health Insurance Program are kids. Medicaid covers more than 50% of our patients at children's hospitals, and and CHIP as well. And it really is the backbone of pediatric coverage. But Medicaid historically has reimbursed pediatrics at a very low rate. So what does that mean? And what are the other key drivers of our shortages in pediatrics? First, as I just said, Medicaid reimbursement for pediatric providers is low. That lower reimbursement translates into lower earning potential, which when combined with high educational debt, which our med students have, can impact an individual's decision whether to pursue training in pediatrics and specifically into pediatric subspecialty or to pick another profession in the medical space, but not in pediatrics, something that will bring them more lifetime earnings and can get them, settled and addressing their medical debt. So, and it's also not easy to get trained to take care of kids or to provide that care. You need to get trained to care for kids from infancy through adolescence. For example, little ones have different size equipment, different tubing, dosage requirements for meds than big kids do. So getting the expertise across all of those ages takes much more time and financial investment. It also takes a truly special person, at least from my perspective, it takes a truly special person to go into pediatrics. Pediatric providers are true heroes, but they also have high rates of burnout and turnover, as taking care of really sick kiddos and their families really is not easy. And we see turnover in other medical disciplines, but in pediatrics, one of the things that is a key factor is we don't have a large pool of providers or resources to backfill when we have those vacancies. And children's hospitals are, as I said, the Medicaid reimbursement is low, so they're often financially strained given their reliance on Medicaid. That means they don't always have their own resources to invest in training programs, in professional development, and recruitment programs to build their workforce, and they don't have resources to backfill when they do have vacancies. So what are some ways that we are talking to policymakers about to help us bolster the pediatric workforce? First and foremost, those solutions have to be pediatric focused. So the federal government over the years has grown its footprint in the healthcare workforce space and has made some solid investments though some of that has been rolled back more recently. However, that investment really, by and large, has been in adult and primary care. And you can see here some of the key ways that federal programs have fallen short in addressing pediatric shortages. So they are typically designed with adults in mind and usually don't have a pediatric training track, especially in the specialties. And that's where, as I've said, most of our workforce shortages are. In addition, many of the federal programs base their eligibility on federally designated provider shortage areas. We've heard from a community health center. I mean, typically they have to serve shortage areas, and those are more, they're often in rural areas, but they are more in lower income areas where there are fewer providers. But as I was saying earlier, children's hospitals typically are in urban centers where we do have specialists and we do have providers because the specialists and providers sort of end up locating there because the children's hospital is there. So we often don't meet the criteria for shortage areas, which cuts us off from a number of those programs. And where we do have a program with a pediatric focus, and there are a couple, the funding's limited, which means the program scope is limited. So, as I said, we need targeted investments. We need to be thinking pediatrics, and we need to be thinking about those investments in ways that are relevant for pediatrics. That doesn't necessarily mean we need to create new programs. That's especially difficult right now, given our current political environment. What it does mean is thinking about ways to target existing programs or expand existing programs so that they can be more pediatric appropriate. And specifically, we're talking about things like bolstering and improving Medicaid, strengthening the pipeline by investing in school and community-based partnerships to get kids and teens especially interested and excited about a career in pediatrics. We have a lot of those programs out there. They're really cool, but they need to be talking about having that career and thinking about career academies in the pediatric area. Investing in programs that are already training pediatric specialists at the bedside. So some of our hospital-based programs, and those programs are that we have programs out there where we're training pediatric advanced nurse practitioners and pediatric specialists and other clinical areas. But we need to support those with some investments so we can grow them. And make investments to bolster hospital-based recruitment and retention programs. We were talking earlier about some of the values-based, programming at the community health centers and thinking about wellness and mental health of a provider in a safe environment. Those things, hospitals are doing those things, but we need to really grow them and make sure they're sustainable. We need some additional investments in that area. And we need to tailor loan repayment programs to pediatricians, pediatric specialists, and other pediatric providers, the non-physician providers, who often are not eligible for existing loan repayment programs. And it's absolutely critical that we do support our healthcare providers' mental health and wellness, and consider ways to ensure that their housing, food, and childcare needs are met, and that their physical safety needs are met as well. And then there's a couple of other areas as we think about the workforce that we look at as both goals for ourselves and opportunities. So we have a severe problem in the pediatric research workforce. We have a shortage. It's pretty pronounced. We have an aging research group of pediatric researchers without a pipeline to backfill. So we really need to invest there. We also need to be thinking, I know we talked a little bit about community health, the community health workers a little while ago. We do need to think about how to bolster that workforce, and specifically a workforce that is ready to work with kids and families. They play a vitally important role in supporting children and families in the healthcare setting. They free up clinicians to practice at the top of their license, and that helps the practitioners better meet care needs. It also can help prevent burnout. And we also need to be thinking about all those innovative care delivery models that can help providers meet the care needs, even in the face of shortages. So there's workarounds that we were talking about earlier, and then also, and thinking, for example, we can think about how to bolster integrative and collaborative care models, how to strengthen our telehealth capabilities and our ability to provide mental health and other services through telemental health. Those models need to be explored, they need to be researched, evaluated, and spread. So just wanted to spend a minute just talking about what we at CHA are doing. We always like grassroots advocates, so if you want to join us in our work, you can reach out to me. I'll get you connected. But we're looking at a variety of different things that we can do to really get our policymakers thinking about pediatrics and moving the ball. So our main bodies of work in the policy space is to strengthen the Children's Hospital Graduate Medical Education Program. That is the only federal program solely dedicated to training pediatricians and pediatric subspecialists in children's hospitals. So it's a vitally important program. We are always working, and we continue to work on bolstering and protecting and defending and strengthening the Medicaid program. We're currently finishing up and excitedly waiting for the launch of a pediatric workforce blueprint that will have policy solutions and highlights how pediatrics is different, where federal gaps are, and what's needed. Pretty much what I've been talking to you about today. And we'll be using that up in Capitol Hill to educate lawmakers and to start conversations with them about what they could be doing specifically. So really, really excited about that. And we are now working on a project on Medicare graduate medical education in pediatrics. And that's to get a really full understanding of how federal funding works to support the training of our pediatricians and pediatric subspecialists. So we can really think about it from a holistic standpoint and think about how we can strengthen those, both combination of the CHGME program and Medicare GME, to really ensure that we're thinking about the future of our pediatric workforce and how to make sure it's strong and able moving forward. And I just wanted to leave you with a thought, and that is that children are our future, and we can ensure that they have access to needed care if we have a strong pediatric trained workforce, because a strong national commitment to our children and our workforce will help ensure their future and ours. And that's it. So I will end sharing.
Jan, thank you so much.
Yes, thank you very much, Jan. That was great. Okay, and then to round out our perspectives before we get into some of the Q&A discussion, we will now hear a patient perspective from Rhonda Monroe, who is founder of Boost, which is Better Outcomes, Optimal Scientific Therapies, US Heart Life Foundation, who's going to be talking about patients at the pulse of care, engagement strategies for sustainable satisfaction. So Rhonda, you're on and available. The floor is yours. See her on, but not off mute yet. Are you there, Rhonda?
See, I'm here. Yeah, I am here.
Perfect.
Trying
Perfect.
to get it to
Mhm.
share. Let's see. And can you see my screen now?
Yes, we can.
And I am in presentation mode.
Now you are.
Yep.
All right, perfect. So I'm going to offer us a different perspective, but one that is equally as important as all of those that we've heard, and that is the perspective of the patient, who is really at the center of our healthcare systems. So the perspective I'm going to bring to you today is that of a patient, but let me tell you how I got here. I was an economist and working in my career, and then 5 days after giving birth to my third child, I had a massive heart attack. And that was the first of three. I also had 2 strokes, 3 open heart surgeries, part of my heart cut off, 15 laser holes drilled in my heart, pericardial window, angioplasty, stents, 3 defibrillator implants, and a whole long laundry list of other ailments. And while I was in the hospital, after my being told that my bypass grafts shut down, 8 months after my quadruple bypass, I found myself in a unique position, having to fight for my own care because 8 months had passed. The doctors felt that I would have too much scar tissue, and I wouldn't be able to survive the surgery. So from my hospital bed, I called the press conference, got the attention of hospital administration, therefore the attention of the surgeons who didn't want to operate on me initially, and got myself that second surgery, which was a repeat bypass, and then ultimately a third surgery a week later for a pericardial window. But while I was in the hospital, one of the doctors that cared for me, my EP, suggested me as a speaker at his former institution, University of Michigan. And so once I had gotten out of the hospital and recovered, I was called out to Michigan. They brought me in as a conference speaker, and the rest, they say, is history. That really launched my advocacy career. Since that time, I hit the ground running. I've volunteered with nonprofit organizations like Women Heart, uh, HFSA, which is really medical society, think tanks. I'm now part of Heart Life Foundation. I have my own unique niche patient advocacy firm called Boost. I've served on the board of directors of 2 community hospitals, and pretty much have looked at the patient perspective in every area of healthcare, from regulatory science to research to hospital systems. And so that's the perspective that I'm going to offer you today. And we went the wrong way. Sorry. So first, I want to talk about patient engagement and what it is. And for the purposes of our discussion, it's active partnership with patient stakeholders, the people who you treat in your systems, who come seeking care from your system. And really, patient engagement is a lot of, it's multifaceted, but it's about the communication the patients receive, the self-management support that they receive, transparency from your system, from billing to diagnosis, all of the information they receive, educational materials, even informed consent if they are participating in research at your institution, and then digital access as well, like patient portals. And so patients aren't the only people, though, who are impacted by this patient engagement. You have to remember that patients have families. Their caregivers come, their children come. And so you need to be able to engage successfully with all of those stakeholders. So what makes patient engagement effective? What can you do as a system leader, a policy person, to make patient engagement effective, not only for your organization to benefit you, but really to serve the patients who are coming to your healthcare system seeking treatment? One of the things I like to say in every realm of patient advocacy is nothing for us without us. Treat patients as partners in their care. Allow us to participate in the decision making. When you're creating materials that your system will distribute to patients about a new diagnosis or something of that nature, co-create that with the patients. There are patient advocates out there who are willing and able to partner with you to design materials that will help you reach your patient population in a language that they can understand, at a level that they can understand, with the concerns that matter to them. And so I urge you to take advantage of that. And then be open and honest. One of the biggest complaints about healthcare is people don't feel like they're getting the full story. And especially in minority populations, marginalized populations, or populations where there are language barriers, there's an element of mistrust, not unfounded, but there's a lot that we can do today to eradicate that. And the first step is open and honest communication. And then I coined this little acronym. Really, it's about the culture that you have in your institution. It's so important. And I believe it was the first speaker who mentioned the person at the front desk. You know, they have an impact on the culture of your organization and the experience that the patient will have at the organization. When I was seeking treatment for my heart attack that I knew I was having, I had an EKG confirmed STEMI. I had to seek treatment 6 out of 7 days, and I was being gatekept by the receptionist in the ER, so that by my fourth visit, she said, "Oh, you again?" Now, I was misdiagnosed for an entire week, and later on she had to recognize the error of her ways. But that was very disheartening for me when I showed up seeking help, knowing that I was having an emergent situation and continually being turned away and then greeted with disdain. And so really cultivating a climate of care, which is an acronym for communication. Just communicate clearly, kindly, consistently at the appropriate health literacy level. Accessibility. Ensure that care is accessible to everyone. If I show up with chest pain as a female, as an African American, as a younger person, I should not be denied cardiac triage simply because of how I appear. And if I were a middle-aged white guy, if I'm being candid, I would have been rushed back immediately and given an appropriate cardiac protocol. So make sure that the care that is available is accessible to all of your stakeholders. And then treat everyone with respect. That goes without saying, but I'm going to say it anyway. And then finally, empowerment. Provide your patients with the tools to feel empowered to manage their health. All of these things are going to help patients, your patient stakeholders feel engaged and cared for, and as a result, they'll interact with you in a greater way. So what are some of the communication strategies? You guys know these if you work in the system. I just noted a couple. The automated and personalized communication, those robot calls that remind you you have an appointment coming up, or a follow-up call after you've been discharged. Those are great as long as they're not overdone, because I will put an appointment in my calendar and still forget about it until I get the call. And then patient feedback mechanisms. Make sure that you're giving your patients opportunities, robust opportunities, to tell you how they feel about their experience. It makes them feel valued, that you actually care about how they were treated. Accessibility. Pretty much everyone has an EHR these days, a patient portal, but it is a great place for patients to access information. I got a call today for a procedure I'm having next week, and I said, well, can you just go over with me the dosing for the medication I have to take in advance? And she's like, you know what, it's quite lengthy. I'll send it to you through the patient portal. And that was perfect. That was a perfect example of making the information that I needed readily accessible for me. And then telehealth, especially in rural areas. I lived in West Virginia for almost 20 years, and a lot of West Virginia is not near a tertiary center. And so telehealth and remote monitoring really make healthcare accessible. Great tools to lead to long-term sustainable satisfaction for your customers if they can, or for your patients, if they can access their providers without having to drive 2 hours. And then respect as a core value. It is non-negotiable. Oh, you again should have never been uttered in an ER or anywhere in a healthcare facility. We are all in this together, whether we're patients or providers or administrators. We are all in it together, and respect is foundational. And not only do you respect the person, but you have to respect their values and what they feel about their health care, because that's going to be foundational to achieving satisfaction as well. And then empowering the patient. How can you do that? With shared decision making, which I already mentioned. But when the reason it's important is because when patients feel like they have some sort of ownership of the path that has been chosen, they're more committed to following it. They're more committed to being adherent to the medication, to the lifestyle changes, and all of that. They're not being told to do it, but they are actually deciding with their provider what is best for them. And then health education and health literacy. Patients need to understand to feel empowered. You know, they need to know not just what to do, but why it makes sense for them to do it. And then support groups and community building. Help patients find a sense of belonging a group with others who experience, because the doctor can say it to you, but it's more impactful. I've had so many patients that I've talked to throughout the years tell me how impactful it was for them to see me thriving, having survived all that I survived. And I apologize for my son's dog in the back. But for me having survived and saying to them, yes, this is possible. If you follow guideline directed medical therapy, if you make lifestyle changes, this is where I was and this is where I am today. And so building those support groups and those communities in your healthcare system will really help to engage patients and help them feel a sense of satisfaction and ownership and empowerment for their healthcare. And then it should go without saying, I know we're not talking about DEI anymore. It's not politically correct. So let's call it culturally competent care. Let's make sure that patients are feeling understood and respected, that they have access to interpreter services, that the education and literacy that I've mentioned several times is available in their native language. And then that staff is trained on unconscious bias. We do things that we aren't even aware of. And it's because we have unconscious bias, but making sure that there is staff training on the topics that may be touchy so that they can provide culturally competent care is going to go a long way to establishing sustainable satisfaction in your system. And then personal access to data, easy and complete access. I don't want to have to go in from 9 to noon on Tuesday through Thursday and sign my life away to get my health records and my clinical notes. Make it easy and accessible for me. It helps me review and prepare for my appointments. It helps me feel more in control. And then it helps me understand where my provider is coming from. If I'm reading those notes, I have a better understanding of their thought process. And then it helps build trust. This is inspired by the HIMSS patient engagement framework, but really this is what patients want. Inform me, engage me, empower me, partner with me, and then support me. If your system is doing those things, you're going to create satisfied customers who will be repeat customers. So what does successful engagement look like? Here's a patient that's been newly diagnosed with type 2 diabetes. They use their patient portal to review the lab results. They access educational videos that your clinic staff popped a link in there for about managing diabetes. So then they come to their appointment and they actively discuss the treatment options with their doctor, considering their lifestyle. And so they're making shared decisions together about their healthcare. And then they use a recommended mobile app that tracks blood sugar levels, diet, and activity. And then when they go for their follow-up, their telehealth follow-up, they share that mobile app data that they've tracked over the past few months that was suggested by the clinic staff. And so this demonstrates multiple patient engagement activities leading to an informed and active role in their own health care. And here's the bottom line, because I'm a bottom line kind of person. The challenges and the opportunities are the same, but on opposite ends of the spectrum. A great experience will advertise itself. So will a poor one. Do you want to spend the time up front building an infrastructure and putting the time, effort, money, and resources on the front end? or do you want to be on the back end mitigating damages of a poor experience? And really the choice is up to your organization. And the bottom line is that there is no choice. You have to engage patients successfully in order to achieve and then maintain sustainable satisfaction scores. Thank you for your time and attention, and I encourage you to act with urgency, work together, and commit to a healthcare future where satisfied patients are engaged and thriving for generations to come.
Thank you so much for that.
Thank you. First of all, thank all of you. And I just love hearing Rhonda speak. The story is, she told her story at a conference about 4 years ago now, and we're leading a very large randomized trial of different ways of treating advanced heart disease that's just enrolling women, Blacks, and Hispanics because they've been so underrepresented in trials. And I heard her speak. I have never stalked somebody as much as I have stalked Rhonda. I mean, I gave her my card. I told her what we were doing. She's a huge patient advocate. And literally, she didn't get back to me. I didn't get her card. I went on to LinkedIn, Facebook, then I clicked onto LinkedIn. I waited weeks for her to actually get onto LinkedIn. And finally, we connected. And we've been working very closely ever since. And, she brings such a common sense perspective that we just don't think about or talk about it enough. So I was inspired by a lot of what you said, Rhonda, and this concept of care. And I was wondering, it's almost like clinics, hospitals, they need to have like a patient-centered audit. Are there any examples of patients or Boost or others that are available to sort of review certain processes of care, certain clinics, certain environments completely from their perspective, communicate? I guess there are, right?
I have one. I don't know, but I know of one I was going to.
Oh, yeah.
I don't know if you're asking.
Well, I mean, anybody. There's a great organization called Earth. Well, their app is called Earth. It's Earth without the E. And they.
I can't hear very well.
Oh, you want to come up and just so the.
Oh, well, sorry. Sorry, I was just mentioning there's an organization that has an app called Earth. It's birth without the B. And this app is used by birthing mothers and especially women of color and others in their family to rate their birth experience at hospitals. And then the data is collected, the data is fed back to the hospitals. And it becomes, I think, a really interesting and exciting tool to do just what you're asking, which is measure what's the patient experience in these specific situations, gather the data, and then they ask the hospitals to collaborate in quality improvement activities based on the data that they get from the app. So just one example that I think is pretty exciting.
Thanks, Ron.
Rhonda, do you have anything to add about sort of this concept?
I
You're going to be
don't.
the next company?
I actually wasn't familiar with Earth. I do like the idea. I wonder if we could somehow get a patient portion in the Press Ganey or HCAPS. Like if we could somehow get in those surveys.
Yeah, I was somehow thinking, those tend to be very high level. I mean, just to actually walk into Will's clinic and describe what to really sort of review how people are treated, what the process is, how they're followed up. I mean, just an interesting concept.
It would be good. I'm certainly gonna look at that Earth because part of my experience when I had the baby right before I had the heart attack. I had delivered 5 days prior to that. But when I got into the emergency room, I should have known not to go back to the same hospital in hindsight. But when I got to the emergency room, and I said my water broke, she was like, "Prove it." Like, lady, this is my third child. And literally was like, "Oh, well, let me go get this thing and you put it in your pants, and if it turns blue, I'll believe you." Well, this is my third child. I know my water broke, but do you see how disparities exist? And so I love this concept of Earth, and John, that's a future project to consider, maybe evaluating how patients are treated.
This is Will. I was just going to add to that conversation that we have a patient advisory committee that meets once a month, and they give us a lot of feedback about what's working, what's not working. And then as a federal qualified health center, over 50% of our board has to be made up of our patients as well. So part of that is ingrained in our culture to get that feedback loop.
Oh, that's fabulous.
It is. I don't know that every hospital board does that, but I know that the boards I was involved in did do that. The hospital boards.
And most children's hospitals do have patient advisory groups as well that the parents are part of, and they actually will bring some of the teenagers when they, and I think some of the tweens when they're able to participate, so they can get, not just the parents' perspective, but the kids' perspective of the care that they've gotten.
I think that would be a great place, John, to sort of create this survey tool and make it available to the patient advisory boards.
Yeah, absolutely. So Jan, I very impressed with what you're doing, where your goals are. And, I hate to call it the big, beautiful bill, but HR1, as it's otherwise known.
Thank you. That's what we call it, HR1.
HR1, exactly.
Yep.
But, its impacts on Medicaid and its impacts on sort of limiting student loans for doctors, which I would think would be a horrific financial disincentive to going into pediatrics. How do you see this unfolding, and how are you responding to it?
I can tell you how we're responding to it. Honestly, I don't know. I don't have a crystal ball on how it's unfolding. I will say it's exhausting, but we are actually, we will respond to the rule. So anytime any of these kinds of things happen, we work very closely with like-minded entities. So the hospital groups on the HR1 and the Medicaid, we had a wide variety of organizations that got together to make sure that policymakers understood, where we tried to make sure that policymakers understood what the impacts are. And there's politics and then there's policy. And the politics unfortunately won on that one. On the graduate professional loan, the new rule that just was released, was that just this morning? It feels like it was just a couple of days ago, but this morning, which would, for those folks who aren't aware of this, as part of HR1, they're changing the level of loans that folks can get when they're pursuing a graduate professional degree. That's it in a nutshell. And the Department of Ed has just released a rule today that would implement that. Again, our hospitals are very concerned about it for exactly the reasons you said about the potential impact on the future pipeline. How do you get your education if you can't pay and you can't get a loan? So we'll be trying, I'm not sure exactly what our exact position will be, but anytime those rules get dropped, we submit comments, we talk to our members of Congress and encourage them to weigh in with the administration. We encourage all the nation's children's hospitals to do the same. When we do that informed by data, and we do it informed by the lived experience from the hospitals, we definitely don't work in a vacuum in Washington. We talk to our hospitals all the time and get their feedback.
Great. I'm just going in reverse order, but everybody had such great comments. But Rebecca, so you talked a lot about psychological safety in the workplace, and clearly very important. What happens when you aren't the boss and you're in a sort of psychologically unsafe workplace? How do you sort of raise the issue and support change? Like, how does that actually happen? And systematically for healthcare, there's lots of, the picture of the ED, of the operating room, they're notorious for, throwing people out of the room, throwing, knives and all kinds of stuff. What do you, I know doesn't happen anymore, but I'm sure it happens more than we admit,
You gave me the hardest question. No, how do
You may want to come up here so people can.
So your question is how do
Well, I mean,
non-leader
in
type? Yeah.
healthcare, you
Yeah.
know, there's a lot of examples of either overarching environments or micro environments
Yeah.
that are not really safe. And, you know, it's nice to say what it should be when you're talking to the leaders and move them to do it. But what happens when you're not the leader?
Yeah. Question.
And you can say there's no answer, you know, it's a,
I mean, when you're, I think part of it too is just honing in on those clinical skills of observation, understanding when the right moment is. You know, so often the raise your hand opportunity passes us by, and later in the day we're thinking, oh, I should have said that. And I think you know, put your own oxygen mask on first, all of those kinds of ideas. I don't have a very good answer.
that's okay.
Yeah.
It's a tough question. Well, you had a tough topic, so.
Right.
You know, finally, and I know we're over time. I'm sorry about that, but I just couldn't let anybody completely off the hook. You know, Will, I was actually overwhelmed by, you know, a 60-fold increase in days of cash on hand, you know, growth in your program budget. And, you know, the way that you develop that culture, but were able to follow through, you know, pay equity, especially across the broader community, tuition reimbursement. I mean, how did you strategically think of, because it requires a lot of financial investment, raising a lot of money, and you're getting paid less and less for everything you do, and you know you can only code so well at an ACO. I mean, how did you go about sort of tackling that, all those challenges?
So a lot of it is transparency, for one. I think one of the hardest parts too, sometimes in an organization, is most organizations break at the middle management level. And without strong middle management, it is hard to get anything done. So we invested a lot of time, energy, effort, and training in middle management because they have the hardest job because they're having to manage up. They have to be the ones that speak up, right? If something isn't going well, they have to feel safe to be able to tell their boss, like, hey, this isn't going well. I think the other piece is as we work to invest in people, the level of accountability went up too. And so I appreciated the comments around psychological safety and that it's not avoiding accountability. And sometimes it is firing people. I was told left and right, you can't fire providers in the safety net. I fired 4. And it was addition by subtraction in the sense that you can get so much more work done when you have a dedicated team that's willing to work hard, help each other. As a federally qualified health center, we run as lean as we can possibly lean. So it's as possibly we can work. And so a lot of it is trying to be smart financially, but being very transparent, communicating and helping middle managers tolerate ambiguity in a landscape that's very uncertain sometimes. And so I would say the investment is in leadership, actually, at the middle manager level that really makes the difference to translate to both health outcomes and better workforce as well.
You know, I know we're 10, 15 minutes over, but any burning questions, any comments? I mean, I just can't thank our speakers enough. Those were really, I mean, every time I come here, I learn so much more and see things so much differently than I did walking into the room, not really knowing what to expect. So I open up the floor if anybody online has a question.
I just want to give another patient feedback tool. Dr. Karen Scott from OE scale.
Yeah. We're trying to respect our participants from abroad. So
Dr. Karen Scott's PRIM OB scale. It is a verified tool to measure discrimination and racism in the perinatal, postnatal period in the hospital and in prenatal care. It is something that hospitals are implementing. No one here, but on the East Coast and West Coast, and there's one in Nashville where she's now located. It's kind of expensive, but it is community driven and it's based off of patient satisfaction, patient surveys, patient interactions, and it is a research scale as well. So it's something that I would highly encourage institutions to try. It'd be great for our land project, but it's a really good tool. It's about $40,000 to implement it in your hospital system, but it is a valuable tool because they did find in some centers that physicians who were rated top by, of course, people who had a good experience were actually horrific to people who maybe had Medicaid or were people of color or spoke a different language or had lower education levels. And they found that also translated to poorer outcomes. So it's a wonderful tool that is available, and you can go to Birth and Culture Rigor and learn about it.
Great, thank you. Yeah, there's a lot of work in that space. We're working with Kim Gregory at Cedars on the CBEX tool, trying to get at the same thing. Well, listen,
I just want to one thing on this topic that I think is interesting, maybe for future, is the difference between patient satisfaction and patient experience,
yes,
clinical outcomes. Because I think, just like you say, and I've had this as well. I have a good friend who I believe was butchered by a physician, and she absolutely loves it.
yeah,
Right. So that is part of why I think CMS, for instance, doesn't talk about patient satisfaction. They talk about patient experience. So it's just another.
Yeah, I think early in our cycle we had patient-reported outcomes and patient experience measures, but we should recycle that. That's a great idea. Well, listen, I can't thank everybody enough. It's a pleasure to have speakers like we had today, and it was a lot of time. So thank you very much, and we'll see you in 2 months.
Yeah, March 26th.